Welcome to Research Renaissance, presented by the Karen Toffler Charitable Trust. We invite you into the stories, struggles, and breakthroughs shaping the future of human health. From cutting-edge brain science to discoveries transforming how we heal, adapt, and thrive, we explore the ideas that matter and the people behind them. Together, we look across diseases, technology, and research fields to understand not just what is changing, but why it matters for patients, families, and the future we all share. Join us as we uncover new insights, spark collaboration, and illuminate the science that can improve our lives. Welcome to Research Renaissance. I'm Deborah Westphal, your host and guide through the future of health science. Joining me today is Dr. Caterina Lasome, a nationally recognized leader in health informatics and digital health transformation. CAT has helped shape how data moves through some of the most complex healthcare systems in our country. So welcome, Cat.
Thank you very much for having me, Deb. I appreciate it.
I am very excited to have you on this podcast. You are a long-term friend. I've known you over 10 years now, I believe. And the work that you do and kind of the intersection that you sit, I find is very fascinating. Not only important, but fascinating. I really would like to start with you as an Army nurse and tell me about kind of that early career and what that meant to being on the patient care side and how really that helps you in today's service to what you do.
Sure. Thank you for that question. So I spent 23 years in the military, actually. And like all military nurses, it's very typical that your very first assignment, they want you to have a really good understanding of basic medicine and surgery. How is it that you care for those major diagnostic categories in that? Because really, that's your go-to-war mission, right? That's what you need to do. So you really have to understand the basics there, and then you build from that. But I think, I started with, 18 months of medicine, 18 months of surgical types of cases, and really built that foundation. But then I really transitioned into informatics after about my second or third tour. And I think that really came in a couple of phases. The first phase, while I was still a clinical staff nurse and my very first roles as a head nurse, is right at the time that computers were starting to become prevalent. So I'm that old. Started off with paper-based documentation once upon a time. But personal, computers were making their first appearance. And then also, I think that is when I first started to realize that the ability to harness data for evidence-based decision-making was really important. I wasn't in a position at that time to do anything with it, except maybe complain a lot as a young junior nurse, why aren't we doing this or why aren't we doing that? As is typical with somebody that's younger and thinks they know everything, right? But when I came on active duty, as I had said, we were still doing clinical documentation on paper. And when I got my first personal computer, I was starting to leverage that for my own behind the scenes. You always have additional duties as assigned in the military. So whether you're doing the schedule or you're doing some training or quality improvement initiatives, whatever other assignments that you have, I was starting to use computers for that. So starting to use basic spreadsheets, starting to look at graphs and charts, and everybody would be wowed, like, how did you do that? But you start to realize that you can present data in a way that helps people consume and understand better. So that started the building process, and then I started using it through school. But it was really, the early experiences of trying to justify things that you want, whether it's we need additional staffing, we need more training in this, we're starting to have med errors or whatever it might be. We have workflow changes or process improvements we want. Being able to pull data out of a system or collect it on the side and put it into a presentation that was readily understandable helped to justify that. So was that informatics at the time? Did I even know that word? No. But was that the foundational set of experiences that I grew over time, that's kind of where that originated from, with some of those early experiences. So learning that you can capture and store and leverage data for not only real-time uses, but then downstream other secondary uses of data and the information sort of started my career, in informatics and moving on from there.
So, Kat, we were talking about informatics, and I asked the question around the hospital operations or versus patient care. Does informatics include both of those, or how do you think about informatics?
Yeah, in that particular case, it's all of the above, out to the larger healthcare ecosystem, and even imagine all the patients that we have that go maybe get some care in one facility, they move, they get in another. So it's the entire healthcare ecosystem, that any place there's a need to exchange or access data, there is an informatics perspective to be had, I think.
So, the delivery between the nurse, the educator, the administrator, any kind of quality improvement that you're doing. Can you just kind of explain what that network is? Because I think people go into a hospital, they have records. I think everything operates fairly well with some, irritation. But can you give some idea of how really complex this is, and when something doesn't work right, what is the size of that problem?
Yeah, it can be very little to very big. But I guess, I think it's really important to kind of situate and help people understand. People hear the term informatics in the health context, but sometimes they don't really understand what that means. And among all my colleagues, we could have debates about what informatics is. But the simple way that I try to explain it when people say, what do you do? Especially my mom, what do you do? It's kind of hard. You were a nurse and now you work with computers. What does that mean? So, when you hear the term health informatics or medical or nursing informatics, informatics, whatever it happens to be, informatics exists in all disciplines. You might be a pilot, you might be in manufacturing, you might be in medicine, you might be, any of a variety of fields. But the way I look at it is, if you can mentally picture 3 concentric circles and where they overlap, that piece in the middle. So think about the first concentric circle basically being domain knowledge. Whatever it is that you have done for a living, you're a nurse, you're a doctor, you're a dietitian, you're a social worker, you're a chaplain, it doesn't matter. You have some domain expertise and you collect data and you practice around that particular domain. So think about that first circle being the domain. That second concentric circle, and there's overlap there, is really about computer science. There's additional training and expertise when you think about computer science. So you're learning things about hardware and software and emerging technologies, systems analysis and design, database management. The list is long. There's all types of elective courses, some mandatory. But now you start to see where you're marrying the domain knowledge with computer science knowledge. And how do you bring those together? That third concentric circle is really information science. And that really is where you gain that additional training and education to think about how people interact with technology. Human-computer interactions, system or user-centered design principles, some of those types of, the social and ethical considerations of using technology. Now imagine all of those 3 concentric circles coming together to that little piece in the middle. You have a domain expert who's leveraging knowledge about computers and technology, and then how it fits together with how people behave with technology or engage in whatever it is they're doing. And in that center really lives informatics. For me, I tend to say health or clinical, and I'll get to that later. But that is kind of what it is that we do, is we're bringing that together so that we can leverage information technology and the people, processes, and technology, if you will, for the benefit of whatever outcome it is that we're trying to achieve. Could be clinical health outcomes. It could be, financial outcomes. It could be operational outcomes. And that's where you're asking about that, the system itself. Well, there's financial drivers in there. There's, billing and coding and all kinds of other types of things. In addition to what you want the patient, you also want a nice practice environment for clinicians on how they use the technology. So when I think about health or clinical informatics, those are all the things that are going on in the back of my brain that I have to consider when I'm working on projects, if you will.
Yeah, you spend a lot of time in the military or help in the military. You have a background in military and then in VA. What unique problems or issues do they have? Because you mentioned mission, but then they have all those other constraints.
I do. The military is, I'll start with that because that's where I grew up, was, within the military. And I think, healthcare is healthcare, generally speaking. A hip is a hip. If you've seen a hip surgery, you've seen a hip surgery. They're highly predictable. You know what the course of action is going to be. And so people in the military are just a microcosm of the larger national population. We have people with diabetes or vision changes or dental needs or a broken bone or whatever it might be. And the care you can imagine would be highly similar. So we have nurses and physicians and care systems that care for all of that. What's uniquely different is the mission driver. So when you're in the military, your primary job is not being a nurse. It's being a soldier. It's going to war. It's deploying. That's what you do. And that's why we're required to go, train with our weapons or go on bivouacs and pop a tent or, dig holes and, foxholes and, all those types of things that you need. But the way the military is organized, those go to war fighters, we call those, the line, if you will, armor, infantry, the basic people that are out there doing the war fighting. If you think about that being in the center, then there's circles of people that, progressively work out. You need beans and bullets, you need healthcare, you need all the support infrastructure. And healthcare is a significant one. So when a unit deploys, you have to be prepared as a nurse, and there's tons of additional training that we get to help support the warfighter. So for example, when you're going into operations and maybe the mission is something where they have a potential for a chemical, biological, or nuclear engagement, where there is, certain populations they expect in urban versus rural environments, where they expect high trauma, things like that. So you have different layers from, we call it role 1 to role 4, which are progressively more and more intense types of care. So we get training throughout our military career that teach us to deal not only with preparation for readiness for deployment in those wartime missions, but also our training occurs in military treatment facilities where we get exposed to soldiers and other beneficiaries, service members that have different types of jobs that get injured, that come in. And that's how you learn the skills and the types of things you're going to support downrange in theater, if you will, when you go on those operations. So my perspective is there is no training environment that is better preparation for healthcare delivery than the military health system, just because you are forced early and often to constantly engage in additional training that can be used anywhere, quite honestly. It just, and coupled with that is leadership training. You progress all the way through your military career to higher and higher levels of rank that increase the scope of responsibility that you have to take on. So while you're learning your clinical skills, you're also learning leadership skills that the military gives you. And I think it's a pretty outstanding preparation for how to work in complex environments, which healthcare is.
Yeah. You've explained to me before about the records that the patient, a military patient, or their medical records through their journey, if you would, through their 20 years or their 30 years, shot records and, deployments and whatever it may be. But when they retire, now they go into a different system, the VA system. And that's a very different system that will be given other health delivery. Can you kind of describe that? Because I I was shocked that these were two separate, and the person, the individual, is kind of stuck between the two.
Yeah. So when you're on active duty, you're getting your care through Department of Defense. The Defense Health Agency is the lead agent for all three services. And you go to military treatment facilities. You are assigned a primary care provider, very much like you would expect going to any clinic on any civilian, facility. You just happen to do it on a base or a post, whatever it is. So, but typically the population that's still on active duty is 45 or younger, right? It's a pretty healthy population. We're constantly we have to keep our weight under control. You're doing physical fitness, you're out training all the time. So there's not a lot of complex disease processes typically that you get. So you work through that, but gradually as you progress and you age, you do different jobs and you have natural aging. And oh, by the way, a lot of the training and the physical fitness that we have to do causes injuries. So you might get, stress fractures, or you had an accident on a training mission, you fell off some obstacle course and you break something or whatever it happens to be. Those things accumulate over time, and we're put in some pretty stressful situations. So less so as a medical person, but think about infantry and armor and air defense artillery and some of the situations where they have to go and train and do their missions are highly stressful, and they're dangerous in many cases. So think about, we call it MOUNT, mission operations in urban terrains. And they're practicing how to rappel out of, 10-foot story buildings or get into things, and they're blowing things up. And, you get injuries, you get hearing loss, you get, fragments that went off somewhere and you get something. So all of those things accumulate and they're documented in your health record. But when the time comes to leave active service, either through retirement or you elect to leave the military when your service obligation is up, so what we call end of termination of service, you ETS, you are then eligible, if you've been in the service for 2 years or greater, you're eligible to receive care for service-connected situations, health situations within the Veterans Administration. That is the follow-on care. And it is not required that you receive your care there, but it is an option and it is a benefit that you have earned. So when you go into that system, the most important thing is that record that you have built over the time you spent in the military is complete, that it's accurate, and that it transmits to the VA. So there is continuity of care from DOD over to VA, and that the care can continue. And most importantly, especially as you are in that transition phase, that all that paperwork comes over so that the VA can do a disability determination. You may have zero disability, but at least you've been through the determination process. But as they go through and they're checking, head to toe, everything, you run through a significant battery of tests. If they find something, you document everything, they're looking at your record. If they find something in your health condition that is not as it should be, and they can say that that's service connected, that helps justify your service connected disability, and then your care for that in the VA is covered, right? Or if for example, I don't get my care in the VA, I use my closest provider that's 10 minutes away, but I have that benefit, and then they're my secondary coverage. TRICARE is my primary coverage. The VA, I can also go there. But that continuity of care and the documentation, just think, I think it was 2019, or it was very recently, the Sergeant First Class Robinson PACT Act that had to do with toxic exposures are really coming to light. So we've had water exposures with toxic elements out at Red Hill in Hawaii. We have burn pits over in the Middle East. There's a variety of things. In fact, there were water contaminations down in, I think it was Fort Bragg, that have come to light. And so not only service members, but family members in that case, if there's documented evidence that you can say, I was in this location at this time, and I was assigned there, and I was exposed to this, then if you've had lung or breathing problems, anything, and they work you up, they can make it incident to and connect it to that. So that continuity of care between DOD and VA, and remember, DOD and VA both purchase and have contracts with civilian healthcare providers, because there isn't a VA or a, clinic, outpatient clinics for the VA. Sometimes with rural locations, people are located pretty far away. You can't just get there. So if you have something closer, the VA or the DoD becomes a payer and not necessarily a provider. But we want the record to come back in. So again, that there's continuity over time. And as you age and perhaps some of those signs and symptoms get magnified or worsen, they can continue to track that and increase. I think, they recommend every 5 to 10 years that you redo your disability evaluation, because sometimes conditions actually get worse.
Yeah.
So yeah, it just fits together. And so part
It's
of our,
something there's just a treasure trove of information. Like you're talking about different exposures, geographic areas, different kind of people, different kind of conditions. Is there a feedback loop on that information? Because you're using it to give care, you're using it to give to individuals through their journey of life. But is there a feedback from this into new systems, new either informatics systems, into diagnosis systems? I mean, how is that kind of changing? Because early on you talked about how you use spreadsheets and notepads and you were collecting things, and people would say, well, how did you know this? And then you would ask for improvement, or you would suggest improvement. As we gather more of this information, is there a feedback?
there is. And do you mean feedback to the individual or at the system level, or all of the above?
Both, or, I think I was actually thinking system level, because, it's, I think there's a lot of civilians that don't necessarily have that kind of oversight that would really benefit, that if you knew where you lived had, toxic spray on cotton fields or something that was causing, this, that this would be very beneficial.
Right. There are. And, the civilian examples mirror to some extent what we do in DOD and VA. So think about the train derailment in East Palestine, Ohio. Think about, other things that might have happened in different locations where somebody got the water situation, for example, in Red Hill in Hawaii, didn't just affect military personnel and their families. That trickle down effect into the water supply affected the surrounding community that had nothing to do with the military. So they need the same types of continuity. And the way that should be fed back into the system is, if you are lucky enough, most people in the US have some access to health care. They're either, through their job, or they purchase care somewhere, whatever it happens to be, or they're getting it through a federally qualified healthcare clinic, whatever it is, they've got a record somewhere. So most of the time they have multiple records. Those records need to exchange information. And that's why exchange standards become so critical, so that if somebody is seen in one location for a situation, the data is in the system. That's why we have health information exchanges. And if health systems participate in a health information exchange, theoretically, you can go out and query that. And if it's standards-based, structured data, that information moves fluidly between one system and another, so that you can bring that up in the context of care and hopefully see that for an individual. That's the same thing that we do, military, VA, large healthcare systems, depending on where you live. It might be the Intermountain out in Salt Lake. It could be the Inova Health System in the, Washington, D.C. area. They're all with satellite clinics and a main, hospital, but they're able to share and exchange information. It could be better. There is definitely room for improvement, because we didn't start electronic health records greenfield, right? Yeah. We all did it at different times. In many cases, we're using different vendors. It queues up information different. And in many cases, even though we have an Office of the National Coordinator for Health IT under the Assistant Secretary for Technology and Policy under HHS, that says, in some cases, they'll come out with these rules that say, you must do this. This is how we're going to pay. And if it's not done electronically, CMS's known for this because that's how Medicare and Medicaid reimbursement occurs, right? You have to submit in a certain format. But where that is not regulated or a standard is not in place, sometimes it's voluntary, sometimes it doesn't exist. Therefore, data are either unstructured or they occur in systems. The same piece of information occurs in two different systems, but they can't exchange because the format is not the same. So that's where a lot of the breakdown occurs. But I can tell you, compared to where we were 30 some years ago, 40 years ago, we're off paper. The biggest push is when they start, the big push came where they moved people onto electronic records and incented that, the carrot and the stick that, came along with, after so many years, you'll be on an electronic record. We probably have in excess of 90% of our nation on electronic health records, and the ability to exchange and see, certainly the big five. We call it PAMPI. I call it PAMPI data. That's what the DoD calls it. PAMPI, it's your problem list, your allergies, your medications, your procedures, and your immunizations. If you know those basic things and somebody is in front of you, you can start to put a healthcare picture together pretty quick and at least get them in the door and start asking a series of questions, if they present to you. Obviously, we want much more than that, but if you had to exchange just a limited amount of information, that's a good start.
Yeah. Yeah, I didn't realize that roughly 90% are already on electronic health records. That's the level of standards, the maturity of the standards. Is it about the same? I mean, because when you when you start getting into standards, that's where the arguments come, right?
Yeah, I don't know if they're arguments. It's evolution, and it's
Different
really
perspectives.
It's different. Yeah, you have different people working on those, but I think there's some standards that are very, very well adopted and used. So, when the government mandates that you will use this electronic standard to exchange data, if a health system receives that message and it is tied, it's incented and says that shall or you will not be paid, adoption and uptake is pretty doggone quick. System changes immediately because otherwise they're not going to be reimbursed. But there are some things that are still evolving where we don't quite know. There's not a consensus in the user community. And this is usually not just national. Sometimes these are international standards. People are very mobile today, so you need things to move. But where that standard is not fixed, sometimes they don't exist, and then you do have those gaps. And that's where it oftentimes becomes incumbent upon the individual or the caregiver to be the transmitter of the information. It's not there electronically, and you have to help communicate and foster that. So, there's a lot of standard setting bodies out there. Health level 7, you've got IEEE, you've got X12, and you've got pharmacy data, and, different organizations doing different bits and pieces. And sometimes they don't do things exactly the same way, or they don't communicate on something. And so it's all stuff that will keep me gainfully employed till I'm dead.
That's awesome. That's awesome. So tell us about this. There was a multi-million-dollar study that you did around usability for automatic clinical practice guides. What kind of set the stage? What was that? And then what did you learn? And, how does this help kind of direct any kind of clinicians, especially with burnout or efficiency? Talk about that a little bit.
Yeah. So a clinical practice guideline is just that. It is a guideline. And generally speaking, you have guidelines when things are very well known and understood. Like the state of the science around diabetes care is very, very strong. We know what it is. We know how to manage it, and we know how to have good patient outcomes for diabetics. It's been around forever, and the clinical community is coalesced. They know what the evidence supporting that is. And so you can take a guideline around that and you can automate it and say that, if a diabetic type 1 or type 2, whatever it is, let's just use type 1. If they come in, they present in your facility, usually every electronic record and, every clinician who's been trained knows that type 1 diabetes, you do A, B, C, and D, and it goes in this progression, and you monitor these particular labs, eye exam, foot exam, whatever it happens to be. That's the state of practice that the clinical community broadly has agreed upon. So once you get that for major diagnostic categories, and there's 24 or 26 of those, the DOD and VA are very, and they're out there in the community. You can query, tell me what, where practice guidelines, the clinical practice guidelines exist. Then the question is, how do you get that practice guideline embedded in your workflow and presented in the context of care so you can document it against it, so it delivers to you alerts and prompts so that you stay in that guideline. And healthcare systems try to make sure that the electronic health record captures those when they are in use and when it's appropriate, so that it can guide everybody to practice in a consistent way, because the evidence shows that you get the best outcomes. Now, if somebody comes in, I'm a type 1 diabetic, I present to my primary care provider, and they've treated me according to the practice guideline, but suddenly I've now hit a different age and I have comorbidities, if you will, and I have fallen off the normal trajectory for a diabetic. It's presenting in a slightly different way. This doesn't mandate that a clinician has to use that guideline. You can always override that, but generally a pop-up will come up. Why did you choose not to prescribe this med or do this particular procedure that is in the normal pathway that you would do that? And they write a little justification in there. It's because they've observed something different, or there's some different considerations. So I think it's really important that people understand, and especially clinicians, when practice guidelines first started, there was a lot of resistance to adopting those because it was viewed as cookbook medicine. The system is telling me how I'm going to practice. What about my clinical judgment in there? And that wasn't the intent behind them, but that's how it was early, perceived to some extent. So, the first requirement then of a clinical practice guideline, before you ever get to the technology delivery and availability of that, is you have to have the evidence base. Whatever the diagnosis happens to be, you want to make sure that there's good documentation. The Agency for Healthcare Research and Quality did a lot of work on that. DOD and VA has done a lot of work on that. And these are all published. You can go to PubMed, pull up, are the practice guidelines for X or Y or whatever it is. So making sure the evidence base is there, that it's well documented, and that the user community in your facility has agreed that, yes, we do agree that this is how we're going to treat type 1 diabetics, right? But then that clinical consensus process, especially when something is new or emerging, I'll just use a DOD example. We had traumatic brain injuries. We had a lot of IEDs going off, whatever it is. And there's long-term follow-up care for that. It could be dementia. There's so much variety in how dementia presents, or any TBI or mental health issues, that it's tough to get clinical consensus that say, for this diagnosis, this is the best way to treat it, because the evidence shows if we do these steps and we document that and we follow that care pathway, we're going to get these outcomes with high predictability. That is a really tough hurdle to overcome, because we have clinicians who've been trained in different places using different methods at different schools at different points in time in our scientific process, if you will. So internal to most healthcare systems, there are governance boards, if you will, that are made up of clinicians with a broad variety. And it'll be, oftentimes you'll have not just clinicians on there, but you'll have different types of expertise coming to bear that might affect that particular diagnostic category. So they'll sit around, they'll have a conversation, they'll see what's in the literature, and then they'll say, we as a health system believe the best treatment for X diagnosis is this particular one. It's already in the published literature, like type 1 diabetes. We concur with that. We want this to be present in our electronic health record. If it doesn't exist, they may go through their own internal process and collectively decide that this is how we're going to treat this diagnosis, because we see a lot of it and we believe this will give the best outcomes. Pediatric asthma is a great one. I think the American Pediatric Society has, a practice guideline for the best treatment for pediatric asthma. and we want that to present. And then once that governance process is there, it's all signed off, then they've got that paper trail. Then they usually turn it over to people like me or the IT department to say, can you make this, show up and be visible in the context of care in our workflow so that the right alerts and notifications come up that remind us to do things, to stay on the pathway, so that process is there. So it really starts from evidence and clinical workflow and decision-making first. And then once that consensus is done and the decision is made of what the clinical care requirement is, then they turn it over to IT that says, we want this to present within our electronic health record, our workflow processes, our policies, our procedures, et cetera. And then downstream from that, they want to be able to extract the critical data elements out of the system so that they can measure and monitor not only compliance or adherence to the guideline, but are we getting the outcomes that we expected, right? Because if you're not seeing what you were hoping to see when you went in, you want to be able to analyze that data and say, what are we not doing right? Or what's different about our population, whatever that happens to be. So again, you want that scientific process to flow throughout every step of the process.
Yeah, what you're explaining leads me to believe that even though sometimes we get frustrated with the quality of our healthcare, that as healthcare gets more complicated, as we learn more diseases, as we learn more ways to treat, that these standards, this kind of practice, workflow, is actually raising the quality of healthcare delivery. Do I have that? Am I understanding that correctly? Or
I think generally the answer to that is yes. That's why, the downstream reporting and monitoring and evaluation of data, we put so much clinical individuals and care team members, everybody in the health system is so overburdened at times with data entry. We are all high-paid data entry clerks, quite honestly. All the way from the front line, the front desk clerk that checks you in. They eventually get your vitals, the nurses, the physicians, then on the back end, the coders, the billers. You go downstream from there, supply, whoever gives you things to take your home O2, whatever it may be. Everybody is doing data entry into that. It is not as easy as you would think to extract information out of the system that you're putting the data in. And that's why, we have almost every single healthcare system will have some type of quality department or analytics department or something where you've got people that will help you get data extracted out of the system. You'll ask for, I'm trying to study X. I think I need these data elements. They will help you, go through that, pull it. You want it from date A to date B. I want only men because it's prostate cancer or something like that, and they'll help you pull that data and then help you analyze what it is you're seeing. Some people are savvy enough to do that. Some people need a little bit of support. But that's why it's so, I think, important to have a very firm understanding of what senior leadership, CEOs, commanders, whatever it is, the people that run the hospital, that run your quality department, that are your financials, whatever it is, the C-suite people, what is it that they are focused on? And how do you, as a direct care provider or an admin support or somebody in there, how do you draw that line and thread that down through the system and say, these are the things that are important for the viability of our organization, whatever that might be. There's financial, there's clinical, there's operational outcomes, but where did the data come from that build the story to tell us, are we meeting that or not?
yeah,
So there's a lot of informatics and analytics activity that goes on that helps to thread that through, build reports, and then, be able to analyze that and present it in such a way that it can be actionable at many levels, at the direct care level, at the operational mid-level management level, at the senior level, so that you can improve over time.
yeah, it's fascinating. So you're CEO founder of Ion Informatics. What was that journey like, and why did you choose to, I mean, start your own company after you'd been through so many different successful positions in the military as well as outside the military?
Yeah, so when I retired from the military, I fully expected to go out to industry and because DOD was my background and I lived in the Washington, D.C. area for my final tour, I thought I would leave the military and go out and work for one of the defense contractors that serves the healthcare environment. And I interviewed and did all that and went through that whole process. But I got one of my old professors in my PhD program was working at National Cancer Institute. Kat, you're retired. We need help over here. You have all this operations and clinical experience and you've done X, Y, and Z. And oh, by the way, you know how to get people in line, some of that military leadership training. We got to, at that time, it was 2009 when I retired, and what was going on nationally at that time, the American Reinvestment and Recovery Act. National Cancer Institute was awash in funds and had no idea how they were going to, what are we going to do with all this money? We think we know, but inside National Cancer Institute, which is the largest institute within, the NIH umbrella, if you will, by orders of magnitude, it's big. They not only, have an internal scientific and research mission, but they also support research worldwide, right? So about 80% of the funds that come into NCI support research external, and then about 20% is internal. At least those were the numbers at that time. And when all this money started coming in, it's like, well, what are we going to do with it? How are we going to track it? What are the priorities, et cetera? So they recruited me, and I honestly thought that was going to be my practice interview for industry or get a job or whatever it was. So I went out, I learned how to buy a suit and do a resume, none of which you have to do any of that. And I remember the first couple times I'm putting on these, clothes, and I don't, where do you put your pen? I don't have 20 pockets anymore, so I just viewed it as a learning opportunity, a practice. But then I got there and started talking to them and realizing how significant that mission is. And what they really endeavored to do was to develop a cancer electronic health record, because they recognize that all these scientific advancements from the research, all the tools for analytics and informatics that they had for not only, building better research programs, analyzing data, imagine too, all the genetic and genomic and proteomic data that is coming to fore at that time. It's like, how do they manage all of that? So they needed programmatic support. They needed, to track those monies, but they also really wanted to bring advances in cancer care to the front line of the healthcare delivery systems for everybody they partnered with. So I had reservations about a cancer EHR because cancer is generally not the only thing people are dealing with. It may be a condition that they have, but it's not generally the only thing. And so it's really important that the ability to document care and capture the critical data elements around cancer or in the context of the whole person. You don't just develop, because then what you have to do is, if you've got this cancer electronic record, but all their other health records sits in a different system, now you have an integration issue, right? So cancer components, cancer-related things, the medications, the treatment, the diagnoses, the staging, whatever it happens to be, needs to be in the context of the complete medical record. But we tried, and didn't go so well. I didn't think it would, but it was a learning curve that they needed to get through, and there was really great experience there. So I did that for about 3 years, but what I really realized is the National Institutes of Health, research in general, is really focused around the principal investigator. The grants go out, they have their research, my study, my data, my server, my this, my that. And there's a lot of stovepipes in that. And what you lose is kind of this strategic integration. And that's kind of the world that I've lived in. And so the two things that I probably missed the most were mission and team. There wasn't a unifying mission that went beyond that focus that they had on that one thing. And that's not where I enjoy living the most is down isolated in one thing. I start generally at a macro strategic level, and then I work down from that. What I also missed were my mission partners, and military leads with team and mission first, right? It's you cross the finish line together. That's not how the scientific enterprise works. So for me, the best alignment for doing everything that I had done previously in my professional career was to get back to home base. And the best way to do that, I could have gone on and I had interviewed with, a lot of defense contractors that work in the health space. But I also had seen the contracting world, which I thought would give me the best ability to select the type of work and the projects that I thought were the best match to my skill set and the most interesting to me. And so I thought, well, I live in the DC metro area. There's a lot of defense contractors. There's a lot of companies I can hire with. I'll just hang out my shingle. And if I flunk out, then I'll go get a job. I'll get a real job. Well, that was in 2009, and I still have my nose above water. And it has worked out the way I generally expected. Is I am working back in my comfort zone. Predominantly, I serve DoD, VA, HHS environment. I am working within the content areas that I know the best. And, when contracts roll over, I look for additional work that are really the best match to my skill set. And there's not a lot of people that have that mix. There's probably 400 or 500 of us that we all know each other. And it's a really comfortable and challenging and stimulating environment to work in. So, I kind of move from project to project. They're, 6 months to 2 years. Some are a little bit longer. Some have been up to 4 or 5 years. But, there's that turnover. And, when you did 20 some years in the military, about 2 or 3 years, I'm getting bored. I need something new. Mm-hmm. And this sort of environment allows me to continue to constantly be stimulated and challenged and have to keep up with that and to meet new people. So it's been a very good fit for me.
Yeah. Yeah, that's amazing. When you said there's like 500 of you, that said, with the background of nursing,
being a clinician,
and then having right at that nexus that you talked about with the technology and the patient, and that's a small group.
It really isn't that large, and there's a lot of clinical informatics across the country, across the world. But there's a far smaller subset that understands the military and the VA mission. Mm-hmm. That's where that number kind of comes from, if you will. And maybe a little bit old, a few more, a few less. But it's that direct understanding, that mission knowledge, domain expertise that is relatively small that allows me to continue to provide support because they're always looking. It's like they can get the informatics, they can get the clinical skills, they can get the computer science and the IT skills. What they don't have is somebody that can bring it all together. And so people like me and the colleagues that I know, many of which are retired military or have been affiliated in some way, GS civilians, other government workers that have been in the environment, are able to translate and express the needs of the organization very quickly, very concretely, very surgically to get in so that when we're working with our IT partners, we're able to communicate that in such a way that it's actionable much faster at a lower cost. It's, pretty good value for the government to have people that just already know the space that, that we have worked in.
Yeah. Yeah, I don't know if you just burst my bubble or with the example of the cancer electronic health records, but on this podcast we've talked a lot about brain health and especially around the dementias and the Alzheimer's, and it's a very complex issue. In a lot of cases, we know what, but we don't know why. If we think about amyloid buildup or tau or and then, the brain is connected to other systems in the body. And, you brought up some of the, some of the environmentals, like, there are researchers working, looking at environmentals that people have or are exposed to that may be causing, might be the trigger of the mutations that happen in the brain. It's probably naive thinking that says there's all this data, there's all this research, there's like is there a way to connect these things and ask the what ifs? Because it touches patients, existing patients, as well as some advanced, advanced ideas and around therapeutics or diagnostics. Do you think we'll ever get there? Or what is, I mean, I just, there's thousands of people working on this, and it's a horrible disease. These diseases are horrible. And, we have a graying economy, and the projections are pretty massive about how much impact this is going to be, not only on individuals, but on caregivers and, families. So, can I have some hope? Or
Yes, you can.
okay,
Yes, you can have some hope.
or do I just become a realist here?
Think back to, I guess it would have been early 80s, maybe when HIV first presented. And, people that were diagnosed with that, and as caregivers, you heard that and you thought it was a death sentence. That was a very trying time. And through research, and I mean, the best way I kind of look at it is bench to bedside and back. That's really the mission of the research and the clinical, the MD, PhDs, the researchers with clinical background. They're taking basic science information, that they have learned, the knowledge gained through basic science research out to clinical trials. And then that gets, eventually they say, yep, this is proven, efficacy, safety is there, whatever it is. And then it starts to become, over time, part and parcel of clinical practice. And then you feed the findings to that. Additional research is always going back, right, to that. So you have this continuous feedback loop from bench to bedside and back. And that's how people that are diagnosed with HIV today, we can now prevent transmission, intrauterine to babies. We have people that can take pills and not have levels detected in their blood anymore, can have absolutely viable, long-lasting lives with that. I mean, would you have thought of that when we first heard HIV? No, right? So I think I'm kind of optimistic for most diagnoses. I think the hard part is that if you are in those situations today, and we know how long it takes for these cycles to run their course, we want to speed that throughput, but you want good evidence so that you're not causing harm. It may not be that you or I reap the benefits of that. It could be the next generation, right? So I think there are things that are causing friction in the system, as I think you called it, friction. And some of that is, clinical data, brain health data that are out there that live largely fragmented or perhaps non-interoperable. So the data are not being shared well. They might exist in the EHR. They could be out in imaging systems. They might be in claims. They could be in social services. They might be on your personal wearables. There might be something very valuable in your watch or something that you're wearing, your Oura ring or whatever, your sleep patterns, other things that are there. And oftentimes it's the integration, it's the fragmentation of the data that has not come together. Therefore, you can't discover the findings. There was a whole class I took in my PhD program that kind of opened my eyes to, I think it was called Knowledge Discovery in Large Data Sets. And that really is this ability to bring large disparate data sets together and turn some of the statistical processes loose on that. In the future, if not today already, AI is going to do that because it can cull through large amounts. So the ideal situation is to discover things quicker, to look for those repeating patterns, those things, and then take them through the next level of testing. I think another thing that is a barrier out there are, we don't have good data standardization in many cases. We don't code things the right way. Whether that's things in the brain area, cognitive status, your symptom severity, your functional decline, maybe recovery trajectories. Does every facility in the country that's treating dementia or Alzheimer, are they all capturing the data in the same way, in the same format? No. Therefore, how do you have the ability to do comparative analysis? It becomes very difficult. So this is another reason why clinical consensus, why data standardization and standard data exchange standards become so important. I think, things like, privacy and consent, there's some trust issues in there. Sometimes people don't want to share all the information. They don't always tell the truth. I mean, look at, drug users, alcoholics, behavioral health issues. I know I've never had a problem. And I'm like, officer, I've never gotten a ticket, right? People don't always want to disclose because they don't know where that information is going. And so that can make your data dirty.
Yeah.
The question is, how do you clean that? So, and then I think we're still relatively early in the curve for analytics and decision support infrastructure. Those tools are emerging. They're better than they've ever been, but we still have a ways to go to say, can we pull this data out? Can we put it through and leverage these types of analytic tools, Power BI, for example, Tableau. There's a, myriad of others that are out there, but being able to use that to pull in, imaging, biomarkers, genetic and genomic information, whatever it happens to be, in both structured and unstructured ways. A lot of our data are unstructured. They might be coming across in PDFs. They might be images, pathology slides that are out there. It's like they've never been tagged or coded or anything. And you have this mashup where all these things have to be brought together to apply an analysis for decision support to that. That is massively complex. So yes, we are making tons of progress, but we're not there yet. So I guess, on a positive note, I kind of look at, things that are happening in those fields with experts is I see things, I don't want to say every day because I don't come up for air every day, but when I'm reading, my professional journals or I'm, staying in touch with what other people are doing, advances are coming relatively quicker than they ever have. It took us a long time to get from paper to our first EHR. But now as we've done that, the timeline, it's almost like IT and chips, and your ability, the time gets shorter and shorter, the technology gets better and better, and it's delivered to the marketplace quicker and quicker. But that doesn't mean necessarily that I have access to it just yet. And I think all of this type of stuff is exactly the same way. I see those changes in the delivery of the type of work that I do, where people will bring these new solutions. You see them at technology, at annual conferences, at on the vendor floor, whatever it is. Ambient, I had no idea until, a couple of years ago, this idea of ambient listening in patient care rooms, where imagine the relief that a provider has instead of babysitting the computer and typing, but the patient's over there and you're asking questions. So how did you sleep last night? And then they're typing. And then how did you do whatever? Did you take your meds? And you're typing. The patient is kind of left out of the process, right? Now, a patient and a provider can have a dialogue and they're not touching a mouse, they're not touching a keyboard because the ambient listening is in the background typing that entire note. So when the clinician leaves that visit and goes back to their office, all they have to do is review the note, make any minor edits they might need and sign it, and it's immediately in the record. That is massively, qualitatively improved for the patient, for the provider, for the healthcare system, the processing of that. And I mean, how far that's come in just the last 2 years. A couple of years ago, they were still doing scribes. Healthcare systems, because clinicians couldn't keep up with all the documentation, they would, hire a scribe to come in. The doc is talking to the patient, the scribe's writing everything, goes back in documents for the physician, and then they come back and sign the note. It's just like, so.
That's huge. That's huge. That brings the human back into healthcare and healthcare delivery because, we've all had those instances where you go in and you have a young trainee or somebody typing in everything, and then the doctor comes in and they're looking at the pad and not you and not really feeling like you're listened to. That's huge. That's amazing. The politics aside, because we don't need to get into that kind of stuff, but you painted a picture and kind of that evolutionary curve. Do you see that, these are going to help kind of narrow some of the inequalities in healthcare that maybe some feel that, if you're in a rural area, or if you're, if you're not as wealthy, well, these kind of things, because you use the internet and you use some of the, those examples. And at the beginning, only people that could afford could have access. And now pretty much Wi-Fi and everything, that's, if you've got a device, which there's ways to get those too, you have access to that capability. What are your thoughts there?
Yeah, the digital divide is real. And I grew up, and my mom still lives in, and I visit frequently rural environments. I live in Idaho. I happen to live in a little suburb city, but 10 minutes from where I live, you're in ranch land and forestry, and things aren't there, and broadband isn't there, and people, I won't disclose what version phone I'm on. It's old. But yeah, there are some differences that are out there. But most people have a phone. A lot of things can be done that way. So I think it really kind of starts to understanding what does the patient need, and what resources do they have access to, and that's a joint responsibility, right? So oftentimes there's a lot more resources available than people tap into, either because they're time constrained, they're knowledge constrained, maybe they're financially constrained. But there's a lot of health systems that are federally funded that have good services and people can access things. So, if we can put some of the structural barriers maybe aside, because it is possible to overcome many of them. It requires a collaborative effort between the healthcare team and the individual. You have to meet somewhere in the middle and say, we can provide this to you, but you either, this is your part in that process, right? So I think if you can get to that, that's a big step forward. And that's not always the mental mindset that perhaps some of the people that are viewed in being in an inequitable state, individuals will say it's because of inequity, and they don't attribute any of that process to some personal responsibility on the other side. So, I like that meet in the middle approach. I like to exhaust all options. That's why we have social workers. That's why we have other people in the care delivery ecosystem that help to bridge those divides. Mm-hmm. Does that mean it's perfect? No. Does it mean we can meet every demand for every person at the highest possible level? No, we can't do that anywhere on the planet. But I do think a lot of the inequities can be mitigated. Not necessarily always by technology, but sometimes there's other things that can be done. So I think the things that worry me a little bit about digital tools are broadband access, because we have large portions of the national population that live in rural areas. I think digital literacy, I'm at an age, and I have a mom that is 85. I could talk to her till she's blue in the face. She is not going to get a smartphone. She's got A, B, C, D, E, F. That's how we do text messages. And when they sent her text reminders on the phone that you have an appointment on this day, she never signed up for text message. It was automatically assumed, and they never bothered to ask, do you have a smartphone? Can you get, whatever it is? And they're sending her big PDFs on something that doesn't register. So I think there is a health system responsibility. There's an individual responsibility to know how to have those conversations. And with people that don't have, a daughter, a caregiver, somebody around them to help them navigate, especially as you get older and technology is flying by you. I mean, I can't even keep up with all of these things, if one more person comes, well, do you have the app? Do you have the app? It's just like, if you ask me one more time to get one more app on my phone, it's not going to look pretty. Yeah. An app is not the solution for everything. You have to kind of look in the totality, if you will. So, that's some of it. And then I think you have to also consider, there are some very valid reasons why people perceive sort of a surveillance state, if you will. If everything is connected, this Internet of Things, I mean, you can get your meds tracked in your refrigerator now, right? And it automatically reorders. Not all people want that level of, when was it? Probably just a couple of years ago, where people perceived, rightly or wrongly, I don't know what the truth is, that when they had the little Echo, the Amazon Echo or something plugged in, that it was listening to their conversations. I don't know if that's true or not, but it's really funny that that's on. I hear something, and then I get in my car that has Bluetooth, and it pops up either a restaurant or something that I was just looking at. That to me is a little eerie. And people are not dumb. They pick up on all of those. So I think, you have to kind of look at the tools that are available and make sure that the right tools are selected for the right reasons. This is an individual decision that has to be taken into account. And think about how busy our healthcare systems are today. It's not like they sit down and have these conversations to help you make these decisions.
Yeah.
Right? So there's work to be done there. I think there's a lot of amazing capability, but I'm not sure an individual app for every nuance in one's life is the right solution, because health and wellness and health care, or medical care, if it so is, it is one component of my overall life. It is not its entirety. And so it can't just be fragmented off into, well, this is my brain health, and this is my orthopedic health, and it's my whatever, and this is my wellness, and my vitamins are over here. And I mean, that starts to get, at the time in the healthcare system, perhaps you have something that occurs. You're newly diagnosed with, a cancer or a mole or you break your bone or whatever it is. At the time that you are most vulnerable and needing support, you are now bombarded with so much information that you have to become your own advocate and best integrator of care. And you lack the knowledge, you lack the expertise, you lack the awareness, you lack the time, you may still be holding down a job and everything else. So how is it that we leverage technology as appropriate to get the outcomes that are best for the individual, for the healthcare system, for our national financial situation? I mean, that's a really complex.
Yeah. Yeah, it sure
I
is.
wish I had a magic wand to wave, but that's why I'm saying we will be employed forever if we so choose, because the more we learn, the more we realize we don't know, the more that is needed in some facet or other.
Yeah.
So it's a lot.
Well, Kat, this has been fantastic, and personally and professionally, I learned from you. Every conversation that we have. Was there a question I should have asked you that you wished I would have asked you? That's important to ask from your perspective of this whole area of improved healthcare delivery and informatics to help do that.
Yeah, I think maybe one thing just to touch on, you and I at one point had talked a little bit about this notion of a learning healthcare system. It's one of the later buzzwords that have come out, what is a learning healthcare system? And in name only in some cases, some places are doing better than others, but what is it about a learning healthcare system, the way data moves, and how is it that we can make decisions, get evidence faster to benefit the care experience, the patient's outcomes, improvement to lives of providers, to reduce burden, to make our system, take some of the friction out of it. And, that's a lot of the really genuine and optimistic hopes for a learning healthcare system. So I spent a couple of years supporting the Agency for Healthcare Quality and Research, and that was one of their big initiatives. So I've worked on that with people that are experts in this, and they're all at different big healthcare systems, and they come in, they have conversations and continue to try to work on that. But when I think about a learning healthcare system, I think about NTSB, the National Transportation Safety Board. So when you have an aircraft that goes down, you have a group of individuals that descend on that place, that tear that thing apart from soup to nuts, that capture every fragment, that lay out the plane, that go through, that look at the black box, that put the pieces back together. And they come to, Maybe it's in a short amount of time, maybe it takes a little bit longer. But when you look at that group of individuals and the expertise that is able to descend on a significant problem, a plane went down, or remember when they were having all the issues with something on the MAX 737, whatever it was. I mean, they got to the analysis. Now they just had some loose nuts on a wing or whatever. Those people get in, and when they're found, they identify that issue, they resolve it. And that turnaround time for the improvement of and the safety of the flying public, that to me is a learning aviation system. Do we have anything comparable to that in healthcare? We don't. Remember the report that came out many moons ago, and we saw, 98,000 deaths per year attributable to medical errors and, things like that. So I think it's really important that people ask that, COVID was a really good example. We thought we had at least something where we could capture adverse, the VAERS system, VARES, the Vaccine Adverse Event Reporting System. And as these vaccines came out and they were starting to be used, that we could input, we could report that. You put the lot number, the medication, the lot number, the expiration date, everything, who gave it, where they gave it, time and date, all going into that system, and that you would have enough sufficient data to analyze to say, is this working, is this not working? Well, that was one thing. Reporting to VAERS is voluntary. Who had time during COVID, when you're masking up, doing everything, to enter all that information?
Yeah.
A lot of people chose not to do that. A lot of people chose not to do it because it wasn't the standard guidance they were getting from their professional association, from wherever. Now you don't need to do that, whatever. And look at what we are discovering 5 years out for the information we didn't know that potentially could have had a positive effect. So I don't know whether or not, I think some of the key features in a learning healthcare system are you have continuous data capture. It's embedded. It's not something additionally a clinician, an admin person has to do. It's a byproduct of your clinical documentation that certain data elements are captured and they're fed into systems and you can quickly extract so people can analyze and look at that. This idea of continuous data capture that's in there for the purposes of quality improvement, secondary data analysis, whatever, allows you to analyze that data, come to some conclusions, and rapidly make a fix, right? Those feedback loops become very, very important for generating evidence and making changes to practice, communicating out a solid message to everybody that's in that community and asking them to change because we have discovered this, and hopefully that people trust that that comes out. And as you know, trust among the medical community, among others, has been severely damaged.
Yeah.
And so that's going to be a rebuilding process. So, another example of a quick turnaround of a learning system was during the 2003, 2004 Iraq, when we were over in the Middle East doing Gulf War, right? And we were getting all of these injuries related to IEDs, improvised explosive devices. So the IEDs, especially, they go over with their Humvees, their different, vehicles and everything, and they're going through, they roll over these things and they blow up. And then we have service members that are losing limbs and getting burns and everything else. And what they quickly, that wasn't a research study. That was individuals at the front lines of battle reporting back to higher headquarters, hey, this happened, this is where it happened, this is how it happened, these were the consequences. And then those injuries would come in and to the Roll One, the combat support hospitals, the forward surgical teams, whatever, and they're reporting what the injuries are. Within a very short amount of time, we understood this is the environment, this is what's at play, IEDs, these are the consequences and the outcomes that are happening to our service members. We need to fix this now or we're not going to have any people. We've got people on Campbell's that are able to take us out because of this or just to bury something. That turnaround, seeing those patterns of harm very quickly, being able then to have that frontline feedback aligned and across everybody. Think about that at a very large level. Everybody that is seeing a particular thing has a place to consistently report that. And then especially if you're seeing the cost of inaction, of nothing being done, is going up very quick. What did they do? They reached out, they said, they took those findings very quickly. They turned that over back to, Department of Defense levels. Almost all of those injuries were documented in the Joint Trauma Registry, the JTR on DOD, had every single patient that had been hit by an IED, where the injury was, what the injury was, what they're removed then from the battle space or long-term trajectory. That was given back to manufacturers of these vehicles that the troops were in. And quickly, they turned around their manufacturing process and they up-armored those vehicles and sent them back over in theater. And all of a sudden, there's layers of protection between an IED and somebody sitting in that vehicle. I don't know about you, but that is a learning combat system, right? So insert anything in the middle of learning and system that you're doing. In our case, it's the learning healthcare system. But that can't be in name only. That has to be collection of data, a place to report, a duty, if not a requirement to report. And then you have to have recipients on the other end that are taking time to analyze that, to feed that back, and to take action on it so the changes can be made in the system so it's quickly fed back out to the front line of the people delivering care. We need to change our process here because we've just discovered X is a better way to go. And people have to trust that bench to bedside circle is going to work.
Yeah.
So those are just a couple of examples where data can make a difference. Systems can make a difference. People, process, and technology have to converge to make that happen.
Yeah. Yeah. That's a great place to land because I think that is the hope. I think that's the hope for so many of the things that people go to a hospital for or go to get medical care is that, that we improve it. And I think that, that convergence of those three, people, process, and technology is kind of a great place to land here. Kat, how do...
Think about your brain research community. I don't know where they meet. I don't know what their best forums are, but they obviously come together and there's probably a set of 5 or 6 diagnoses, dementia, Alzheimer's, TBI, whatever it happens to be. But each one of those communities is specialized, could pick a problem to solve and all get together and say, from our vantage point, our healthcare system, our academic center, our research, we're going to focus on this. We're all going to commit to doing this. We're going to all row in the same direction, and we're going to report out our findings as a community. And, there has got to be something in there that makes that loop work faster and more efficiently if everybody is rowing in the same direction.
Yeah. No, I think that is the hope. And we do see, not just conferences and places to share, but we see a growth of places to collaborate and to work together. And I think that's what you're kind of talking about there. Kat, how do people get a hold of you or to partner to get your expertise? How do they get a hold of you over there in Idaho?
Cat.com? No, I'm just joking. No, my company is Ion Informatics, ioninformatics.com. It's ION Informatics. But, Deb, I don't know when the transcript comes out, if people watch this, the phone, email are the best ways. I am in front of the computer working all day, every day. So my email is CAT, at ioninformatics.com. Again, Cat at ioninformatics.com. And my phone number is 703-975-2287. And you are free to call me. I love to collaborate. I love to learn and, help people move their projects along. It's fun. It's exciting. I'm on LinkedIn. If any of this content's been interesting and you just want to connect and maybe have a discussion at some later point, I think it's under just my first name and last name, Caterina Lasome. It's a little bit different spelling, Caterina, Lasome, Lasome. And find me on LinkedIn and connect. And I am happy to work with anybody on anything that's going to help outcomes.
That's wonderful. I appreciate all your time, all your wisdom, all your insight, all the little technology problems that we had at the beginning of this podcast. It was not easy, but this has been very informative, and it's just really, really good to see you, my friend.
Absolutely a pleasure. Thank you for inviting me. This is a new community for me, and I'm thrilled to be here and stuff. So thank you for the opportunity.
Thank you for joining Research Renaissance. For more information and to stay updated, subscribe for more episodes and visit our website at tofflertrust.org. Feel free to call us if you have any thoughts, suggestions, or just want to find out more about the Karen Toffler Charitable Trust. Until we meet again, onward and upward.